Um, one of the goals of the center really is to better integrate medical and psychiatric care. And it has always been a career interest of mine. I've done things with HIV care in patients with serious mental illness or hepatitis C. So COVID-19 comes along, and it really allowed me as a personal interest to do something that I've always wanted to do, but always failed to do. And that is looking at preventive care, specifically actually vaccinations in patients with serious mental illness. So this is a great example about the really the pressure that COVID-19 put on all of us to do better for our patients. I do think this example, I'm going to describe a small pilot project to you from our clinic, but I think this example will have assume a larger, has a larger message for overall healthcare for patients with serious mental illness. My disclosures I put for completeness here. I have no funding for vaccine research or anything. So let's just go to this slide here. And let's stop for a second and think back where we were last winter, okay? So last winter, the pandemic had already had a disastrous, beginning, and we were heading into winter. And then a study came out that showed the risk factors of mortality from COVID-19. And the one very established one, we knew this for a long time, was age. Number two, however, was having a diagnosis of schizophrenia. That was the second largest risk factor for dying from COVID-19 if you contracted it. Now, shouldn't have come as a surprise, perhaps. I made this little diagram here, which I call the tragic epidemiologic triad of SMI, serious mental illness, and COVID-19. It really depicts, how this works. You got to have a highly infective agent, so that's COVID-19. You got to have a vulnerable host, and you have to have an environment that is permissive, that allows the agent and the host to come together for the host to develop an infectious disease. And the vulnerable host, there's many reasons why patients with serious mental illness like schizophrenia are more vulnerable. The medical comorbidities on the left here on the slide, obesity, smoking, lung disease, diabetes are just other examples. So I think in the end, the diagnosis of schizophrenia really just flags people as having other causes of other reasons to be vulnerable. Now, how do you address an infection? We cannot really change the infective agent in this case. We did work with the environment, obviously. We try to prevent crowding, social distancing, all focuses on this aspect of this triad. But we certainly would love to turn a vulnerable host in an invincible host. And December 11, Pfizer first, then Moderna received emergency use authorization for vaccinations. So this is all great and great testimony to progress in science, but here's the problem, okay? So this, what you people called Operation Warp Speed to develop the vaccines, that alone is insufficient, because you cannot just have a vaccine, you need to have a vaccine program. If you have somebody, take yourself, the first question is, well, there's a vaccine, will I accept the vaccine? And some of us, or may you have worked through this and overcome it, may have had vaccine hesitancy. Oh, I don't know, I'm unsure, let's wait a little bit. For other people, even those who are willing to accept the vaccine, there's practical barriers to overcome. How I'm going to get to the vaccine site, a mass vaccination site, who's going to drive me, how much does it cost? And then for some people, remember at this point, most vaccines got to have 2 injections. How can I remember the second injection? How do we make sure that people follow through with the completion of the vaccine series? So we thought about, this is the problem. Can we be part of the solution? We meaning our little clinical team here in the Eric Lindemann Mental Health Center, the Freudenreich Clinic. And shout out here to my small team with Caitlin, Ben, and Sarah as the nurse practitioners, and Christina Schnitzer, one of the MDs, together with me and some other clinical staff, and the leadership of North Suffolk Mental Health Association, which basically allowed us to do something that made total sense to me. And I'm going to use this term to re-medicalize a mental health setting. Now, what did we do? We set up a small quality improvement project. We basically said psychiatric providers are a missed opportunity to be part of the solution to increase vaccination rates in patients with serious mental illness. We have a lot of trust. People have trust towards us. We have a skill set. You know, I'm a physician. I know something about vaccines. Motivational interviewing would be another skill that we have to move people, you know, from vaccine hesitancy to vaccine acceptance. And we have frequent contact with people. And we really tried in our clozapine clinic to have a more delineated group of about 200 patients to say we're going to achieve 90% vaccination rate. And we did this really just by keeping track, by developing a process, by engaging the whole clinic, by having meetings about it. I don't have the final numbers yet. We're not quite there at 90%, but we are absolutely at this point at the rate for the general population about 70, almost 80%, which to some extent I think is already a success, because we've basically shown that there's a group of patients often left behind. They do not have to be left behind. We picked that as a target date for the final numbers, actually June 30th, because it's close to the 4th of July that President Biden had announced, by which we really wanted to. We also want to give people time to really have a choice, because you might remember earlier, you know, the vaccine was not widely available, but it really has been. So we had basically 6 months to work on this project. So here's my thesis again, that preventive care, vaccinations, is really something. It's a legitimate role for a mental health care system. It really matters to patients. In this case, a very clear cut to reduce the risk of dying from COVID. And we have, you know, this was really just a pilot to get our feet wet, to see how acceptance here in our clinic and patients had been, to my mind as a physician, has been a very positive experience. I really like this part of my work now. And we have other ideas. It would be nice, for example, if in the Freudenreich Clinic, we would be able, with the help of a pharmacist, perhaps to have a mobile clinic. Many of my patients asked me, you know, why can you not just do it? And there's many barriers to that, including regulatory barriers. I do think, though, and I'm going to end in a second, there's a broader message here. This effort goes beyond COVID-19. I think the annual flu vaccines, for example, are also not going to go away. So this is something we can focus on, and not just in our clinic, but perhaps at the larger systems level. And finally, I think it also does show that, you know, we can address vaccine equity at so many levels, including at the level of clinics. And what a waste if we don't take advantage of that. So I in the spirit of, you know, one metaphor that was used earlier, we don't actually need to build it. We have it. We actually have an infrastructure, but we need to figure out, and that's the dissemination piece perhaps down the road, how we can change attitudes. That's not my role. You know, we'll leave it up to medicine. Well, we are part of medicine. And I hope I convinced you to some extent that it's a worthy effort. And I look forward to questions later.